All right. So today's talk will just mostly be over what we call Alzheimer's disease, which may have many of its own questions. And that's been an evolving definition, especially as we start to think about potential medications to modify the proteins that we're going to talk about. But I really want to highlight today, too, that it's not always memory. So if you ask the exact same memory questions to every single patient, there's going to be a pretty large percentage of Alzheimer's disease that you can miss too. So that's one of the things I want to highlight with this talk. No disclosures for me. From an objective standpoint, so updating a little bit of our definition of what is Alzheimer's disease, and that's still an ongoing debate. But then when we think about like the different ways Alzheimer's disease can present with brain changes, one of those is with something called posterior cortical atrophy, or which is more of a visual variant of Alzheimer's disease. So I'll give you a few things that you can consider if you're ever wondering if a patient has this, some simple tests to add on. And then progressive dysexecutive syndrome is really something that we're just learning more about, but it tends to be in much younger folks. So I just had a patient today that was 46 years old with this progressive dysexecutive syndrome. If you look at Blue Cross Blue Shields, they put out a news release a couple of years ago saying young onset Alzheimer's disease was increased about 210% over the last 5 to 7 years. That's really just us being able to recognize it, to be able to diagnose it, to be able to test things like spinal fluid biomarkers, to be able to test things like an FTG PET scan. I don't think it's any more prevalent necessarily. It's just we're able to recognize it better. So I'll give you some practical recommendations for those types of patients as well. And then we'll have a slide on sort of that relationship with the age of onset and the clinical phenotype. So when you think about Alzheimer's disease, it is essentially, you have to think about it in two ways. So we're learning that Alzheimer's disease doesn't happen overnight, right? This is something that happens over years to even decades. And there's, so one way to think about it is from a cognitive stage, right? So we've talked about this in the prior talks of does somebody have normal cognition, especially on very, detailed neuropsychologic testing? Do they have mild cognitive impairment? Do they have dementia? But then what does their biomarker profile look like when we think about things like amyloid, tau, and N stands for neurodegeneration. So this ATN model, this is a research model. This is not something that, is like ingrained into clinics, but it's something that we use as a specialty clinic and something that most clinics are going to be using once this becomes a standard of care. But the A stands for amyloid. So we're able to measure amyloid through spinal fluid, through the blood, or through an amyloid PET scan. So there's multiple ways to find out is somebody amyloid positive or negative. And then there's also tau, which is the T. And specifically for Alzheimer's, we look at something called phosphorylated tau, which we can measure in the spinal fluid, the plasma, or with a tau PET scan. And then we also look for neurodegeneration, either evidence of shrinkage of those memory structures, which we've looked at in prior talks on the MRI scan, or an FTG PET scan showing evidence of failing brain networks. And then there's a new blood test called neurofilament light chain that may or may not prove to be an alternative way to mark this in. And there's plenty of, this is what we have right now, but like, for example, we're doing skin biopsies to detect synuclein, so the protein that causes, Lewy body disease and Parkinson's disease. Any biomarkers that we start to get can be plugged into this model to where we can get a better picture of, well, what exactly is driving the symptoms. So let me give you two examples. Somebody that has dementia, but completely normal biomarkers, amyloid, tau, and that we really don't see shrinkage of the memory structures like we would expect. It'd be really hard to call that Alzheimer's disease dementia, right? That would be a completely inaccurate description of what is causing their dementia syndrome. It may be vascular dementia. It may be Lewy body dementia, right? So that's where these biomarkers start to become important of what we're calling things. And it's going to become really important if we start to think about, well, are we going to give a drug to somebody that's going to clear out amyloid? They better have amyloid in their brain, right? We better have evidence of that. And so all those drugs, if they do fully come to market and things, or if there's going to be next generation versions, you're going to have positive biomarker tests to be able to even qualify for those drugs. So that was the point here. Just to review kind of the typical Alzheimer's presentation, it's at least over half of the presentations of Alzheimer's disease are sort of amnestic or short-term memory problem example. And so someone that presents for multiple years of short-term memory symptoms, those examples being repeating questions, repeating stories, missing appointments or medications. These are the ones of where we really call it an amnestic predominant presentation. And they'll often have difficulties with delayed recall on testing. And as we've looked at in the past, this correlates pretty well with shrinkage of the short-term memory structures, the hippocampus. However, there are other ways this presents. So here's a 61-year-old who presented to their ophthalmologist for visual blurriness, kind of a vague visual symptom they were experiencing. At their eye appointment, they detected mild cataracts, but surgery didn't seem to resolve these symptoms. And then about 2 years into symptoms, the eye doctors started to notice that they were having some visual field deficits in the left visual field. And then 3 years in, they're getting lost in familiar locations. There's also some report of inattentiveness from caregivers. And then about 4 years into symptoms, they see a cognitive behavioral neurologist because these symptoms are progressive. And at this point, they're having issues with dressing apraxia, so difficulties with trying to get the arms in the sleeves and getting clothes on appropriately. They're having troubles reading, and they can't find items in the refrigerator and pantry. And they, on a cognitive screening test, so my short test mental status, they're in an abnormal range, but it's in a mild cognitive impairment range, but they're missing all the points on the cube and the clock. So 4 out of 7 points comes from visual spatial testing. I don't know who is marking on my screen here. I don't know if I can get rid of that. So simultaneous agnosia is what we call this when someone struggles to sort of interpret overlapping objects or multiple objects in a scene. And so I'll show you an example of that. We'll give you a few options to test with that. On an MRI scan, this is what the general read was. So generalized cerebral volume loss. However, when I kind of took a look at the scan, the front part of the brain here looks normal for age, but the back part shows a lot more spinal fluid collection because there's been shrinkage of the back part of the brain. And that is essentially, the area that we, that is part of the visual spatial system. So it fit with kind of what I would expect based on the clinical history. So we call this posterior cortical atrophy. So the back part of the brain being the visual spatial system, the posterior region, and then cortex, cortical, and atrophy or shrinkage. And so what does like some advanced neuroimaging look like with this? It is essentially where the back part of the brain is struggling to use glucose. So this is an FDG PET scan where we can see the back part of the brain much more than the front is struggling to use glucose. So this can be a confirmatory test if maybe the MRI isn't quite as revealing. And then on the research side, we can do things like a tau PET scan to really prove that yes, tau is the protein that's driving these symptoms. So over 90 and even up to 95% of posterior cortical atrophy cases are due to Alzheimer's disease. And so we know that through studies like this that look at that tau protein that's driving the changes. The initial misdiagnosis is very common, partly because we haven't really had consensus criteria even for how to make a diagnosis of PCA or posterior cortical atrophy. The most recent consensus criteria was in 2017. So I list that in this paper down here. We think it's about 5 to 10% of all Alzheimer's cases are due to this visual variant. And it's often that they'll see eye doctors first. So the eye exam is typically normal, meaning the visual acuity is fine, but then they're struggling with either field of vision changes or more complex visual assessment. And so the current criteria suggests, well, one, is there evidence of neurodegeneration, meaning that there's been a gradual progression? It's not like a stroke that happened suddenly, right? It's not like a tumor was found, or there's other clear eye issues that could be causing these symptoms. And then is it posterior predominant? So that's the posterior aspect of this neurodegeneration. And so either evidence of that occipital lobe or parietal lobe shrinkage on an MRI scan, or glucose metabolism on an FTG PET. And then do they fulfill criteria of at least some things that would fit with this part of the brain? And so these are complicated behavioral neurology terms, but basically troubles with calculation. So that's one that's easily asked about, right? Are they having troubles calculating a tip, doing the normal bills and things like that? We talked about that one earlier, dressing apraxia, so troubles getting the clothes on and off. One of the most common ones we found in our study of this is environmental problems, like navigating an environment or depth perception issues. And then the most common one is reading difficulties, so staying line to line while reading. And this is usually in sort of sparing other domains, meaning like speech and memory. It's more of a visual spatial issue. And so in our Mayo Clinic study, where we looked at these folks in detail, 65% were females, which fits exactly like what we would expect to see in all causes of Alzheimer's disease. But the age of onset was 59. So it was an earlier onset presentation, although there was quite a range there between 45 and 74. And the initial symptom in most patients was troubles reading or judging distances. Nearly all of our cases were 90 to 95% Alzheimer's disease. You can have some rare CJD causes, so the prion disorder, and then corticobasal degeneration can cause this. And then certainly Lewy body disease could cause a visual spatial syndrome. However, usually we're able to separate those a little bit better on history and exam. Here was the age of onset in another study, where theirs looks like it was somewhere around age 57 as the peak there. You can see sort of the range here, but certainly younger onset than 65 for most folks. There's a pretty neat study where they look at eye tracking. So you can hook someone up to an eye tracking device and just have them read a paragraph. And this A here is typical Alzheimer's disease, the TAD. You can see that line to line, they do just fine reading. They may struggle to remember that, in 5 minutes, but the process of reading is just fine. Whereas folks with posterior cortical atrophy really struggle to maintain that sort of line to line aspect of things. And so like one of the ways to help them read is, one, increase the print. So like a Kindle reader is helpful. And then also utilizing some sort of, paper, usually with good color contrast, so they can kind of stay line to line as they go through, can be helpful. So it's a simple test that I will sometimes pull up. I'll just even Google Navon figure, right? And I've got a little PowerPoint presentation I'll bring up in the clinic, but this one on the left is a Navon figure. It's just basically, are they able to see not only the small e's here, but are they able to see the big picture, the A? And so patients with posterior cortical atrophy describe like, it's not like they're looking through a straw. They can see a little bits and pieces of the picture, but they can't see the whole picture. So they may struggle to see this larger letter. And then same thing with these incomplete letters, they would struggle to fill in that this is an E or an N. And then another one that I'll do with them is this overlapping figure, where are they able to see the 5, objects within the overlapping figure that may not be present, for them. Like they may see that this looks like an 8 here, or this looks like a turkey head, but they can't see that it's part of a larger teapot, right? So some practical, getting them involved with occupational therapists, maybe low vision clinics. Simplifying the environment at home can be very helpful from a quality of life standpoint. Increasing contrast can be helpful because they're having difficulty differentiating. If there's a bunch of shades of white in the house, they're going to really struggle. They can have falls on the stairs because they can't judge the depth perception on the steps. And so having contrast color strips and really there's a lot of things that can be done day to day to help their quality of life. Better compartmentalizing and better organization in the things in the house as well. So it's a distinct phenotype of Alzheimer's disease. This posterior cortical atrophy it's often present in younger patients. So if you've got a patient that's in their 50s, they're having some mild memory issues and having a lot of visual spatial issues. Sometimes they present with multiple car accidents, right? And we can't figure out why they're having car accidents. That can certainly be a presentation as well. Asking about reading, right, is one thing. And then sometimes, what I'd recommend to eye doctors and things is at least have a test that can test the simultaneous agnosia just to see does that explain their visual symptoms, even though their visual acuity might be normal. And then obviously I think getting neuropsych testing in these folks would be pretty important if the suspicion is there. So the second case, very similar age, but a 57-year-old with 4 years of anxiety, depression, cognitive concerns. Their husband works, quite extensively, 60 hours a week. He's not really aware of any changes. He mentions, well, she's not really getting lost. She's doing her usual activities daily. It's mentioned that she's not currently working, and so you ask a little bit about that. Maybe she hasn't worked, but she was working, but was fired from her job as a lab tech. And then you find out more information. There were some difficulties keeping up with tasks. She was becoming less efficient, having to double check work more often, making mistakes with measurements. And so it's really important to ask about these types of questions if there was any sort of reason why she was no longer working, because that might be clues of what's going on. She was struggling to adapt to new jobs on 2 different occasions. So, couldn't really learn new protocols or deal with any new computer applications. And at that point, she was diagnosed with depression. And there was a grieving process after her mother died of Alzheimer's disease around this time frame. So when we think about kind of like ways to ask questions, right? If you just asked her or her husband, is she repeating herself? Is she missing bills? Is she missing medications, speaking appointments? You may get no to those types of questions, but we're really thinking more just based on some of the history we've gotten that this might be more of an executive level problem, meaning difficulties with working memory. And so there's different types of questions you can ask about that. And so oftentimes troubles with complex work tasks is our first clue. And so on further questioning with her, she was, so like family really did enjoy playing board games. And all of a sudden she was really struggling to keep track of all the moves that were happening, as well as the different rules. So she had to keep having okay, what can I do in this position, right? Needing those instructions repeated multiple times. She was struggling to cook larger complex meals, difficulties with calculations, planning, organizing, multitasking. Another good example is like putting furniture together because there's all these steps that one has to go through. So all these things were starting to show up when you ask about those specific types of issues. Brain MRI scan was read as unremarkable. And then detailed neuropsych testing it said there was multi-domain impairment, meaning, memory, different types of executive function, memory, attention were affected. But the degree of cognitive impairment didn't match with the sort of reported activities of daily living. And so there was actually this question of whether this was all psychiatric or pseudo dementia that was raised. Here was the MRI scan. So her memory structures here, the hippocampal structures, look normal, whereas the back part of the brain does not look normal for someone her age, and not necessarily the occipital lobes, but more of this parietal lobe area. And when I did kind of my little short testamental status screening, one of the things that this test does pretty well with is test the parietal lobes, particularly with mental calculations with the cube and clock. and then also with immediate recall. So I could see very quickly that she really struggled to encode information. So when I said, okay, remember these 4 words, she would need those repeated almost immediately, right? And then struggled with calculation construction, just really kept needing things repeated multiple times throughout the testing. And so then another thing I'll do is just sort of like a sequence of 3 things. Like if they can copy me while doing this, great. And then I take that stimulus away and see if they can do the 3 sequences on their own. So we call that a Luria motor sequence, and she could not perform that task. And so we proceeded with getting a glucose PET scan in this case, given some of the uncertainty on diagnosis. And this is what the PET scan looked like. And so you can see the parietal lobes right here and here are lighting up more, brighter areas, which is abnormal in this scan, gray being normal. And then you can really see this frontoparietal network. And you can imagine how this could really mess with executive function or working memory type of changes. And so this is not anxiety, depression related. And now we have clear evidence of this. And this progressive dysexecutive syndrome is commonly seen in these young onset patients. And we expect it somewhere between, it's probably closer to 10% of Alzheimer's disease cases. And like I said, much more common in our early onset folks. But we do see it in older folks, maybe like 1 out of 10 or 2 out of 10 dysexecutive syndrome cases are older. It's usually in my highly educated individuals, but we don't exactly know why that is. And so our sort of, push to get this recognized in the literature, we used Alzheimer's disease biomarkers and FDG PET scans to really confirm the diagnosis in a large series of patients, and they all look very similar to this case. In our sort of experience of going through these cases, misdiagnosis is extremely common, especially because we're dealing with an age group. Like I just mentioned earlier, I had a 46-year-old today, right, that's had 3 years of symptoms. Most of the time, these are diagnosed as anxiety, depression. Sometimes we'll see pseudo-dementia diagnosis. That's the most common misdiagnosis. And then frontotemporal dementia, because of the frontal, executive dysfunction, is commonly a misdiagnosis as well. And the delay in onset, or the delay in diagnosis from onset of symptoms, is usually about 4 to 4.5 years. So pretty similar to the PCA folks. These folks can respond quite well to acetylcholinesterase inhibitors. So we'll even push those doses higher to even 10 milligrams twice daily if they're able to tolerate it. Usually the side effects is what limits us. And so if they're getting benefit at higher doses, but they're getting side effects, then we'll switch it over to a ribostigmine patch to try to reduce some of those GI side effects. They can actually do pretty well with driving as long as they're not distracted. So like as simple as like even having a conversation in the car while driving, not really allowable for them because they can't multitask. And so like if they're able to plug in the GPS, this is where I need to go, they can do the task of driving fine as if they're not having, if they can think about just that and then have the GPS navigate them. And then they do better if things are simplified in multiple step chunks. They need to write things down very often to keep track of those steps. And then if something really needs to be remembered, repetition can help. Anxiety is extremely common. I should have mentioned that in the PCA folks too. So in both of these younger onset disorders, anxiety is extremely common. Most times because their memory is working fine. They realize something's wrong, but they don't, it's hard for them to, kind of understand what that is. And so SSRIs can really help. It really helps with this, I call it kind of like the worry loop, right? Where the anxiety levels go up because they're struggling to solve a task or think of a word. And that anxiety and stress level increasing in the brain does not help one solve the problem. And everything, it snowballs. And so these SSRIs, usually Lexapro or escitalopram or sertraline is what we generally stick with. And I have found that SNRIs can sometimes worsen some of these symptoms, just to keep that in mind. So what does age have to do with it? It's pretty interesting. If you look at like tau PET scans, which really tells us where the tau is in the brain, the early onset folks, it's really kind of spread throughout, but really heavily hits these frontoparietal brain networks compared to our late onset folks here in the middle, where it really seems to be more of the temporal lobe presentation. And so the difference between the early onset and late onset folks seems to be this frontoparietal network. And so that's sort of what we're found. That's what we're learning as far as how these cases are slightly different. I should mention one other atypical or different variation of how Alzheimer's presents. And so I just have one slide on this, but this is an example of a primary progressive aphasia presentation of Alzheimer's disease. This is where someone presents with more progressive word finding difficulties. They may be losing their train of thought, and it's out of proportion to just the memory symptoms. And the epicenter of this variation of Alzheimer's disease is really along this language network, this left hemisphere of the temporoparietal brain structures here. And so this is a different cause of Alzheimer's disease. And you'll read that like primary progressive aphasias are grouped into frontotemporal dementia disorders, but this is the exception to that. It's due to Alzheimer's disease. When I first joined at KU, I really kind of kept track of patients. And so out of 620 new patients I saw over that 12 months, you can see that, so while the majority were still the amnestic phenotype, the sort of classic short-term memory issues, and they're generally older, we had plenty, and obviously we're a specialty referral center, but there's plenty that are the non-amnestic phenotypes. So this posterior cortical atrophy, this dysexecutive phenotype, and then the language phenotype. So they're out there, right? And it is something to keep in mind when you're, especially when you're seeing somebody younger that's having cognitive issues. So as we sort of move forwards, right, these Alzheimer's disease is really defined by these biomarkers, not just is it a memory problem. And these things are going to be more and more of a general workup that we're doing, especially in patients that might have abnormal neuropsych testing. Is it due to anxiety, depression? Is it due to early Alzheimer's? I mean, this test can tell you pretty quickly, right? More definitively what the cause is. And it's just important to realize that these things can present differently depending on which part of the brain is involved. And it seems to be that in younger folks, a different part of the brain gets involved more than our older folks. And brain network level changes is really what we look for on these PET scans, and they can be a good tool for visualizing these patterns and helping us understand why someone's having the symptoms that they're having, and also helping confirm the diagnosis as well. Because in somebody that has like anxiety, depression, the PET scan is going to come back looking more normal than not. And so that can be reassuring too, if that's the case. All right, so I'm going to go ahead and stop there, see if there's any questions here. So stop. Yeah, so good questions. What is working memory? That is a great question. So I think the best, so like when I'm doing my little short testimonial status, the best example that I can give you is when I ask them, remember these 4 words, and then I say, I'm going to say the 4 words, I'm going to have you repeat them so I know they made it in there, right? When I have them repeat that, they don't get all 4 words the first time, or even the second time, sometimes the third time. Sometimes I have to repeat it 4 times for them to even be able to get the 4 words in there. That's really the immediate recall. That's the working memory side of it. And then if I can get them to stick, especially if those hippocampus structures are relatively, normal, they're going to be more likely to be able to remember them on the delayed recall portion or the short-term memory issue or short-term memory portion. Another example is like with mental calculations. If I say, okay, what is, 29 plus 11? And then they think about it, and then within a second, they lose track of what numbers they were even calculating. That's a working memory problem. And so it's really, can you sort of juggle information in your head and, sort of rearrange that information, get it and execute a task or get an output, right? other examples is like following a cooking recipe, right? Where you're having to go step by step through something. That's different than a short-term memory problem where you forgot that you were cooking and you left the stove on, right? That's how I would explain that difference between the short-term memory and working memory. And then for the patient presenting with amnestic symptoms typical of AD, would you order MRI brain scan? Yeah, I would. Yeah. I mean, I think it's important to still be able to document that this is not a vascular etiology, right? So you get vascular information from an MRI, and make sure they don't have any other structural cause of the symptoms they're having. And for the young onset folks, they tend to have a more normal looking MRI, although, and so it'll almost always get read as normal, or it'll say generalized atrophy. But what I'm always looking for is, am I seeing changes along those parietal lobes, because those are where I would expect the epicenter to be in a young onset patient. So those are some of the clues that I look for. But usually for somebody that's younger, I'm wanting more confirmation than some sort of subtle change on an MRI, right? So I'll often go the extra step of getting either the spinal fluid testing and or the PET scan, because both those can kind of help solidify the diagnosis. All right. And there's another, so I know a few of our neuropsychologists are on. So there's been some discussion of kind of validity measures, especially validity measures of whether someone's their cognitive testing results are valid or not. And in these folks that really struggle with working memory, it's pretty hard. So my former colleagues at Mayo kind of published a recent paper on these dysexecutive impairment patients, and they may struggle with some of our validity tests because they're just so, they can't even remember what you asked them in some of the validity measures. So it's something that we just have to have on our radar, and knowing that we have more objective options, right? With spinal fluid testing, with PET scan testing. So if something doesn't seem right, that's something to consider, rather than just kind of saying, well, this is probably all anxiety depression, because in many cases it is. That's much more common than young onset Alzheimer's disease, but this is out there, and these are things that, if we could intervene sooner than kind of 4 years delayed diagnosis, that could really impact patients. Yeah, so that's a good question. How to differentiate FTD from dysexecutive syndrome and AD? So it's a good question. The reality of the situation, like, you would need biomarkers in many cases, because I say that because you can also have a more rare behavioral variant presentation of Alzheimer's disease where the frontal lobe is more involved, and the biomarkers will be normal in an FTD, but they'll be abnormal in AD. But you can have executive impairment in both FTD and AD. And so it'd be accurate to call it more of a progressive dysexecutive syndrome, with the differential being FTD, AD. The main thing that's going to help you in FTD is are you getting clear behavioral changes? So that's really down to the history. So are you getting, they're struggling with, their social environment, the social cues are being ignored, they don't have that social decorum, they're making rude comments, that especially out of character for them, right? Major personality changes. That usually is more seen in FTD than it is in dysexecutive AD. Our dysexecutive AD folks might have a lot of apathy and anxiety. So those are usually the two psychiatric symptoms we see in dysexecutive AD, but we usually don't see, the changes in diet or the changes in social decorum and things like that. That would lean me more towards the FTD. But because they can both have executive impairment on cognitive testing, you can't rely on the cognitive test to come up with a etiologic diagnosis in that scenario. So antidepressants, cardiac diseases and dementia, I mean, that's a broad question. Cardiac disease is a lot of things. I mean, for patients that have QTC prolongation, that's the main concern with SSRIs, but I think starting the SSRI, having a baseline EKG, having a cardiologist or a primary care doc measure the change on an EKG after starting an SSRI, I think those are all reasonable steps, because the SSRI is by far and away the most effective, especially from an anti-anxiety medication. So I think people really have to think about, well, how can we get this on board and follow it and make sure it's not causing any issues? Because for most people, it doesn't cause issues from a cardiac standpoint. All right, we are a little bit over time. Excellent questions. I will, it looks like, I think, yeah, so Dr. Burns will be on discussing kind of how we're trying to connect your patients with research on June 16th. And so we'll look forward to seeing you guys then. Have a good weekend.